So first of our talk is about all valvular heart diseases, and this is very important because, as you know, as the population is aging in the United States, there are a lot of patients with valvular heart disease, aortic stenosis, mitral regurgitation, and tricuspid regurgitation. So we will discuss all of them today, and also the hypertrophic cardiomyopathy. So with that in mind, I wanted to talk about the aortic stenosis. So the typical clinical situation that you should know, few things. One is the clinical presentation. So severe symptomatic AS, and I'll just show you very briefly that that is a class 1 indication to do something about aortic stenosis. There is no medical treatment for severe symptomatic aortic stenosis. So this is important to keep in mind. Then we will talk about the asymptomatic patients, because just yesterday in New England Journal there is a new article that came out. So this is an important thing to keep in mind, that what do we do about asymptomatic AS? Then what do we do about the moderate AS? And then something to understand about what is a low flow AS. So we'll talk about that. And then the diagnosis in recent times is different. That of course we do echo, but CT and MRI and the cardiac catheterization are all somewhat important to keep in mind. And then the two options we'll discuss very briefly. So this is the outline of the project. So the investigations, when we do the three terms that are coming out that are important, is gradient. As you know, the gradient is the pressure difference between the left ventricle and the aorta, and I'll show you. Flow is the cardiac output, so how much is the flow across the aortic valve, and the aortic valve area is the area of the aortic valve, and there also is some importance to keep in mind, and the catheterization. So the gradient, as you see the gradient here, so this is to say that this is the left ventricular pressure and this is the aortic pressure. When you talk about gradient, there are a lot of different terms that come out. The peak gradient, the mean gradient. The peak gradient is the gradient that you see at any point in time, the highest gradient in the left ventricle, highest pressure in the left ventricle, and the pressure in the aorta. So as you see here, the pressure in the aorta and the pressure in the ventricle are not peaking at the same time. So they peak at a different time. So peak to peak gradient is slightly different than the highest gradient that you record in the echocardiogram. So let's say your aortic systolic pressure is 120 and LV pressure is 140. It is not necessarily 20 millimeter peak to peak gradient, because when the pressure in the left ventricle is 140, the aortic pressure may not yet have reached 120, it may be still 100. So the peak gradient can be higher than peak to peak gradient. So this is an important consideration. And the second is the mean gradient is the area that you integrate here. So this is called the mean gradient. So these numbers are super important to keep in mind. And obviously, if you have a small opening, and if the blood is not enough blood is passing through, the gradients will be less. So this is another important thing to keep in mind, that the gradients are not necessarily telling you that exactly what is the tightness of the aortic valve. The second thing is this, that when you measure the valve size, so you measure the valve size. So remember, this valve is opening and closing. It's the heart is beating, so it opens to, let's say, 1 centimeter square. Then the next second it is 2.5 centimeters square. Then it becomes 1 centimeter square, and then it closes. So it opens and closes. So when you measure the valve area, you are measuring a valve area that is either a mean valve area or a peak valve area. So mean valve area means during the systole, how much is the valve size during the entire systole, and you measure a mean. Or you measure a peak, meaning that what is the maximum opening of the valve. When we are writing the guidelines and all these things, the numbers that you see is something called mean valve area. It's not a peak valve area. So in the echocardiogram, you measure the LVOT VTI, meaning that velocity time integral. So you are integrating. So velocity time integral, and the valve, and the LVOT area also keeps moving, it changes with systole. So it's a very complex situation. And then you have the aortic VTI, and then you measure the valve area. But so in echocardiogram, what you see, 0.6, 0.7, 0.8, is a mean valve area. And when you see the CT scan, let's say IV planimeter or a TEV planimeter, it is a peak valve area because it's the maximum valve area. We don't typically mean it. So there can be some discrepancy between these two numbers if you are seeing the patients. This is a fairly simple thing, but it's good to know. So here, if you say the grade of aortic stenosis, so that you have aortic valve sclerosis, then you have a mild aortic stenosis, then you have a moderate aortic stenosis. So we say moderate is anywhere from 1 to 1.5, 1.4 centimeters squared, the valve area bias if you go. But there are a lot of different things that determine moderate. But just the valve area, if you are going to say mean valve area, is about that much. Severe is less than 1 by ACC/AHA guidelines. And mild is more than 1.5. And if you look at the grade 4, is severe symptomatic aortic stenosis. So there is no question there. Aortic valve replacement is necessary. So Dr. Braunwald, anybody who reads a little bit of things, they always cite this particular graph from Dr. Braunwald to say that when you see these people who develop symptoms, you are falling off the cliff in the sense that you are going to die in whether 1, 2, or 5 years, depending on what symptoms you are experiencing of aortic stenosis. And he came up with this just from 12 patients, amazing, 12 patients information. And then, then subsequently there are another 50 people but this was a very, very old paper, as you can see, that he came up with. When the aortic stenosis became a problem and we said that, okay, we want to do a TAVR trial, FDA ignored this. They said, hey, come on, you have to do the TAVR trial where people are not surgical candidates. You now randomize them to medical therapy. There's no medical therapy. So they said that you randomize them to medical therapy versus TAVR because they are no surgical candidates. So we randomized them, 179 in each group. Very painful experiment. We published it in Lancet there. And we verified what Dr. Braunwald said, that in 179 patients, everybody died, at 5 years. This is, very, very painful. One patient was alive without AVR, just one patient. So my message is that if you have aortic stenosis, severe symptomatic aortic stenosis, please refer them for treatment. There is no medical therapy, say giving Lasix or giving this or that. It's not going to work. So this is a very important thing to keep in mind. Now there is this concept of low flow, low gradient AS that is important to keep in mind. So this is the flow part that I was telling you. So if your cardiac